I think, gastrointestinal problems are the biggest problem that in practice we see with our patients in pregnancy. And now that Dr. Sharda Jain Madam has covered one end of the gastrointestinal system, it's time to come to the next. And probably the commonest thing that we see is patients with hemorrhoids or piles in pregnancy. We are quite at our wits' end many times on how to deal with it as gynecologists. And unfortunately, many times patients may not want to go to a surgeon at that time, and unless there's a surgical treatment required, and they look for recourse from all of us gynecologists. So it's extremely important for us to get an insight on how exactly to manage these patients. And I think we are privileged today to have Dr. B.B. Agarwal with us, because he's a very esteemed and renowned surgeon, and he will be able to share tips and tricks on how to manage hemorrhoids in pregnancy, which every gynecologist should have in her armamentarium. Dr. Agarwal is Vice Chairman and Professor, Department of General and Laparoscopic Surgery at Sir Gangaram Hospital and Sir Gangaram Institute of Postgraduate Medical Education and Research. He is the first Indian surgeon to do STAR or staple transrectal resection of rectum for rectal prolapse. He is the first in Asia to do the TransStar surgery, first in Asia to do the PopStar procedure for pelvic organ prolapse. He has numerous international and national honorary appointments. I think we are honored to have Dr. Agarwal amidst us today, and at least I am very excited about hearing what he has to say on the topic. Over to you, Dr. Agarwal.
Sorry, sir, you're muted, sir.
Okay. So good afternoon, everybody, and thank you, Dr. Meenakshi, for a very kind and indulgent introduction. And I am grateful to Delhi Gynecological Forum leadership, to Dr. Sharda Jain, whom I have seen as teaching my wife at Lady Hardinge College, and Dr. Mala, who is a very competent robotics surgeon and colleague who keeps me on the toes by doing many surgeries so efficiently that I always wonder how to match up to her skills. And thank you, Dr. Yogesh. We were colleagues for many years, and our wives are batchmates from Lady Hardinge and good friends. And thank you, Team Abbott, for organizing this wonderful academic feast. I bring greetings from my institution, Sir Gangaram Hospital, and thank you once again for inviting me here. And most of my talk is based upon guidelines from American College of Colon Rectal Surgeons, plus many of my publications, plus being editor-in-chief of Indian Journal of Colorectal Surgery. I've been writing guidelines for Indian colorectal surgeons, including some chapters in the textbook of colorectal surgery by the association. So it is not moving forward. My presentation is not moving forward. Hello? Hello?
Vikas, can you please check?
My presentation is not.
Yes, ma'am. Yes. I'm on this side. Yes.
Yeah, so now it has moved. I was stuck up on the first slide. So as I said, the talk is based upon international guidelines plus my publications, and these are some of publications from me which are relevant to today's talks. And whenever I start a talk, I believe that we have three kind of loans or debts which we pay back in our lifetime. One is to our parents, to our ancestors. Second is to the society, whatever resources we use to become doctors and practice surgery. And finally, to our teachers, by imparting knowledge to our younger generation. So this is, I think, a wonderful opportunity for the final debt that I owe to the society and my teachers. And in this picture, you see all presidents of European Colorectal Associations who visited us at Gangaram Hospital on my invitation. So these are again some of those friends. I became ambassador of SAGES for India. Coming to hemorrhoids and anal fissures during pregnancy and after childbirth, We should remember, as Dr. Meenakshi said, most of the gynecologists would be keen to know that there are no safety data available for any of the compounds that we surgeons use in conservative management of hemorrhoids, including some of the very simple things like xylocaine cream, nifedipine, or calcium channel blockers. There is no data. We just use them from common sense that they are harmless medications and that they are topical and they should not cause any harm. But there is no level 1 evidence to support, but they are reasonably safe. I'm saying this because nowadays there is a trend of using bottle and injection for Fishery Nano, which should not be used in pregnancy. I added this because I found no evidence or no reference, but I have seen some of my colleagues talking about using it in pregnancy, so it should not be used. Second most important thing is that we should remember that in pregnancy, more and in general population, most of these benign conditions can be treated by lifestyle and diet management. That is what we train our patients to be more active. Don't sit prolonged hours at one place. Keep walking in between if you have an office job, and go visit toilet only when you have a pressure to pass stools. Don't sit on the commode and try to pass stools forcibly. When it will come, you will have sensation, and when you feel there is enough pressure, only then visit. And most important, increase intake of fiber and water in your diet. So these will comfort most of the patients, especially in pregnancy. And if they fail, then we can think of topical treatments, applications, which I'll be talking about. And almost 100% pregnant ladies will be resolved with this management. They will not require the touch of a surgeon. Forget about knife of the surgeon. So very few might require a surgical consultation that during pregnancy trimester, last trimester, or up to 1 month after delivering a healthy baby. So what is so special about pregnancy and benign anorectal conditions? What are the risk factors? We know literature has consensus that almost 1/3 of pregnant ladies suffer from some kind of benign anorectal problem during pregnancy. Most of it is in last trimester or in the first month after delivery. But in some studies in Western literature, it has been reported that almost 2/3 or even up to 85% of ladies during pregnancy will suffer one or more symptoms of benign anorectal disease. And there is again a consensus that much of it can be treated by taking care of lifestyle and diet. As I said, increase fiber, water in the food, increase activity, whether you are pregnant or not. Don't sit at a longer time at one place, and do not visit commode or sit in the washroom unless you have a good enough pressure. Literature has consensus that these problems are common in last trimester and 1 month after delivery. The risk factors in pregnancy are delaying the bowel movements or constipation. Then a lady getting pregnant with previous history of having benign anorectal conditions. Another risk factor is related to the growth of the baby and duration of the pregnancy. The late delivery after 39 weeks of gestation and birth weight of newborn more than 3.8 kilograms is associated as an independent risk factor for problems during pregnancy. And some studies, rather latest studies, say that partial or stress or straining for delivery for more than half an hour, or some say even 20 minutes, is an independent risk factor for benign anorectal condition manifesting in first month after delivery. So what is the baseline given by American College of Colon Rectal Surgeon? That we should initially evaluate all these people suffering from benign conditions with proctoscopy or endoscopic evaluation of the sigmoid, that is sigmoidoscopy. And our first emphasis should be to correct the lifestyle and dietary habits and toilet training of the patient. If this does not help for a reasonable time, which is not defined in literature, but in a pregnancy situation, which may be as short as 3 days, we can offer office-based treatment to these ladies, which is, I'll be talking about that. And there is no role of surgical treatment of benign anorectal conditions largely in pregnancy, except for a thrombosed and inflamed external hemorrhoid. Why it should be treated within 3 days? Because it can get gangrenous or it can get infected and cause a perianal sepsis, suppuration, and perineal abscess, which is not desirable. So only when you see a thrombosed external discolored hemorrhoid should you be feeling urgent about referring it to a surgical colleague. Surgical hemorrhoidectomy should be reserved only when everything fails, and especially in grade 3 and grade 4 hemorrhoids. So what is the approach? As we know, they will resolve on themselves. So modify the diet, activity, and lifestyle. And you can teach them what we call as Kegel exercises, because they increase the tone of the anal cushions. They induce a venous flow. They induce absorption of the lymphedema. They reduce swelling, engorgement, and they reduce the chances of prolapse of the hemorrhoids, hence reducing the chances of thrombosis or bleeding or inflammation or suppuration. So Kegel exercises are known to everybody, but in India, they are nothing but they are what we teach in yoga as Mula Bandha or Vajroli. Mula Bandha is squeezing your anal canal and rectum like you would do when you don't have a convenient place to defecate and you have a strong urge to pass stools. So you squeeze your back passages, pull it inside your tummy and keep it there. That's Mula Bandha. Vajroli, similarly, if you have an intense desire to pass urine, you don't have a convenient place to pass urine, you're not socially placed to pass urine, you squeeze your urine passage, squeeze it inside and pull it inside your tummy. In pregnancy, apart from training patients about these pelvic floor exercises, asking the patient to lie down in left lateral position will will reduce the venous congestion, as we all know. And patient should be repeatedly told about diet, lifestyle, and things like stool softener, so that there is no precipitation of symptoms by exaggerated constipation. So I have repeated many points in my first 3 or 4 slides because the topic is surgical, but this is one condition, especially in pregnancy, that a surgeon and a gynecologist have to act like a doctor without a knife. So Osler said, a surgeon is nobody, but a physician who can also do surgeries. So it is most applicable to pregnant ladies suffering from benign conditions. So we all have to be physicians who also know how to operate, and we don't have to apply our tools, modern tools like staplers, botulinum, and laparoscopy, or whatever you call. A fool with a tool is still a fool, I say. So Einstein said any fool can know, but the point is to understand what the patient is suffering from and how we can relieve the patient. And as a surgeon, we should always keep in mind that surgery leaves not only a scar on the body, but it leaves a scar on the mind of the person suffering from post-operative recovery, as well as if things go wrong, the scar on the psychology of surgeon, the operating person, is also there. And we should not be one-trick surgeon. We should understand the things holistically and come and offer our patients evidence-based treatment, which is least invasive and which will relieve the patient. So, and anorectal surgery, I always include this slide, is the mother of all surgeries, because it was a successful treatment of a fistula of a King of England, which granted us a Royal Charter of Royal College of Surgeons, or gynecologists included. Before that, we were not indulged by the society, we were considered barbers. So coming to the main topic, as we all know, hemorrhoids are nothing but connective tissue which is rich in vasculature, engorged veins with some arterioles. That's why the bleeding is bright red. If they are lying cranial towards the head and side of the dentate line, they are internal hemorrhoids. If they are lying below the dentate line towards the outlet, they are external hemorrhoids. And in India, it's quite a common problem as it is in West. How should we evaluate these patients in pregnancy? We should always take history of the symptoms, which can be pain, which can be bleeding, which can be perineal difficulty in maintaining perineal hygiene, or which can be just prolapse, making the patient feel uncomfortable. So after taking all these histories and seeing that there is no past history, we can again offer what I repeatedly say: modification, a slight modification in lifestyle, make her active as much as possible, ask her to lie on the left lateral posture when she is to lie, increase fiber in her diet, increase water intake, and use stool softeners only when necessary. After taking history, we do a digital rectal examination, which includes visual inspection that there is no perianal inflammatory pathology like pruritus or suppuration or a thrombosed hemorrhoids or an evolution of abscess, which can be seen by erythema or cellulitis beginning. Then we have to do proctoscopy or sigmoidoscopy, and we all know the grading of hemorrhoids. Grade 1, they are never outside. There are symptoms, but your patient doesn't see them outside. Grade 2 is patient sees them outside and they go back inside after defecation. Grade 3 is they go back only when person tries to push them in. Otherwise, they stay out. And grade 4 is irrespective of effort by the person, digital manipulation or a squeeze, they will stay outside. So these are 4 grades, and these grades are important because management is dictated by them in parts. When should we do colonoscopy? That is very important in today's era of evidence-based medicine and Consumer Protection Act. These are the 4 indications. First one I have struck because age more than 50 years, most of these pregnant ladies will be below that age group. Otherwise, anybody who has not had a colonoscopic examination in last 10 years and has bleeding per rectum is more than 50 should have a colonoscopy. Even if the person is less than 50 but more than 40, or he is 10 years younger than a family member who has suffered from a colorectal malignancy, again then you should do a colonoscopy. And even irrespective of age, if the person has 2 first-degree relatives who have had colorectal cancer, then you should do a colonoscopy. And other 2 investigations are presence of occult blood in stool as done by immunochemistry is an indication for colonoscopy. So again, there is highest grade of recommendation as there is level 1 of evidence and grade B of recommendation for conservative management of benign colorectal conditions. As I said, diet, increase fiber and water, fluid, lifestyle, go to the toilet only when there is pressure, don't sit unnecessarily, do walking regularly before meals or after meals. Before meals is better, and avoid sitting at a place for a long time. Once this has been instituted, patient continues to have symptoms, use what we call as flavonoids, which are flavonoids, will increase the venous tone and increase the lymphatic drainage, decreasing the edema and congestion, causing less pruritus, less congestion, less prolapse, and less difficulty in maintaining perineal hygiene. But these medicines, although common sense tells us are safe, there is no, because there have been no prospective randomized controlled trials, so they don't have a level 1 evidence, but they have a higher grade of recommendation. So level is 2, but recommendation is B, so 2B evidence. If this fails in pregnancy, these things will not fail. But say in 1 or few % of patients, if this fails, you can offer them what we call as office treatment, which is ambulatory, which is painless or causes minimal discomfort and does not require an intensive post procedure follow-up. So these can be rubber band ligation, sclerotherapy, laser coagulation. And laser coagulation is nothing but energy-based devices, which can be cautery-based, radio frequency-based, laser-based, or ultrasonic-based. So they are energy coagulations. So idea is to fix the connective tissue which is sliding down to the lateral pelvic wall or lateral rectal muscles so that there is no prolapse. As it is believed now, hemorrhoidal cushions are normal in population. They become symptomatic only when they slide down and stay below the dentate line. So in pregnancy, what happens? There is increased intra-abdominal pressure. Because of the effect of the hormones, the sphincters are relaxed. So the cushions which slide down do not come back naturally. Otherwise, you know, if you watch cows and animals doing defecation, the lower rectum comes out, and when it is over, they squeeze the sphincter and goes back. So it happens in human beings also. But if the sphincter is not tight enough, if it is relaxed, if because of the intra-abdominal pressure it is open, then cushions slide down and don't come back. So the principle of hemorrhoidal office-based treatment is to induce fibrosis of these potentially prolapsing connective tissue cushions to the lateral pelvic wall so that no symptom of hemorrhoid arises. What are the side effects or complications? They are very rare. That's why these are preferable procedures. They enjoy the highest grade of evidence and recommendation, that is 1A, because complications are very rare. But if they happen, they are because of the local infection, which can spread to the perineum, causing perianal sepsis and pelvic sepsis, and which manifests initially as a urinary problem with mild low-grade fever. So rubber band ligation, it relieves symptoms in almost 90%. Recurrence rates are high, but in pregnancy, that is not the issue. So it is a non-invasive. It is better for grade 1 and 2. In grade 3, it should not be applied because it may cause a lot of pain. And it is contraindicated if patient is on anticoagulants, because when the strangulated pile, because of the bending, sloughs off, there is a lot of bleeding. Sclerotherapy has no contraindications, but it is slightly risky because if injection is not given in the right place, it can induce portal vein sepsis, or what
we call as portal pyemia. Rest of energy-based coagulation devices I already talked about. If everything fails, then we surgeons can excise the hemorrhoids, what we call as classical Milligan-Morgan hemorrhoidectomy, or if we close the mucosa, which becomes Ferguson. But closed hemorrhoidectomy is nothing but open hemorrhoidectomy after one passage of stools. The surgeons who say, I do closed, my American colleagues, President of American College of Surgeons, Dr. Steve Exner, speaks in his talks all the first day it may be closed hemorrhoidectomy. The moment patient passes stool, it is again conventional Milligan-Morgan. Nowadays, we do stapled hemorrhoidopexy, which we call it hemorrhoidopexy because we do not remove anal cushions. As I said, these cushions are necessary for cleaning, hygiene, and maintenance of incontinence to flatus. So hemorrhoidopexy, we pull up the cushions and fix them there by a stapler, what we call as MIPH, minimally invasive procedure for hemorrhoids or stapler surgery. All surgical procedures have incidence of up to 2% or even 5%, some reports say, of bleeding, which needs to have a relook, and post-operative urinary retention in up to 15% of cases, which will subside with conservative management. So what is the evidence for these procedures? Excisional, the open surgery is gold standard, but we don't do it because long-term results of open surgery might be better, but short-term, that is analgesia use, pain, and return to activities faster with stapled hemorrhoidopexy. So my choice is stapled hemorrhoidopexy. So what is our practice, whether pregnant or non-pregnant? We inform our patients, and my bias is towards stapler surgery. I don't fast my patients for more than 4 hours. I walk my patients of all surgeries, whether hemorrhoids or gallbladder or anything, because that is a best guarantee against deep vein thrombosis. I use general anesthesia. I avoid spinal because spinal is associated with more post-operative urinary retention and patient not being able to ambulate for certain hours. And also being a teaching institution, it's not a good practice to use spinal because you can't talk freely to your residents. You can't teach, otherwise in practice patient will say, you were teaching on me. We don't give any post-operative IV fluids, and so that there is no retention or sudden filling of the bladder, and all patients are ambulated within 2 hours with resumption of normal diets. In pregnancy, my special emphasis is to tell that all decision has to be made by gynecological colleague. We inform the patient as well as our gynecologist colleague. It is she or he who take an informed consent. And Dr. Mala will remember day 4 yesterday, we did a cholecystectomy. So I always do a pre-operative ultrasound for fetal well-being a day before surgery and immediately post-operatively for medical legal purposes as well as for my mental peace. So my aim is to restore within 48 hours that the person is normally active, can take a normal bath, fulfill the home or office commitments normally within 48 hours, can eat the spicy diet within 48 hours, can resume whatever exercises she was doing, and can have a normal family life. A few slides about fissure in ano. We all know it is a tear, as the name suggests, it's a crack or fissure, extends from the dentate line towards the anal verge. It can be, usually it is posterior in 90% of population, but females can have interior also. Anterior is not, females will not have interior, but interior is commoner in females. In minority of population, they can have both anterior as well as posterior fissures. If it is neither anterior, non-posterior, it is lateral, then it is atypical and needs to be evaluated for possibility of malignancy, tuberculosis, or sexually transmitted diseases or inflammatory bowel disease. So laterally placed fissure, always get it examined thoroughly by a surgeon. It can be acute if it is less than 6 to 8 weeks. If it is more than 6 to 8 weeks, we call it chronic. The features of the chronic are the patient will have a sentinel pile. Most of the females will complain about that protrusion of a flesh piece. So that is a sign of chronic fissure, or they will have a hypertrophic papilla or granulation tissue apart from visible fibers, shiny, silvery white fibers of internal sphincter will be visible at the base. In acute, they will not be visible. Acute will be erythema and patient will have anal spasm. So they usually come to us with severe pain at the attempt to defecate, and the pain stays for a few minutes to many hours after defecation, even making a person unable to sit comfortably without touching his bottom the patient is sitting on the edge of the stool or table without letting the back passes touch the surface. Fissure can also cause bleeding. Bleeding usually is not in drops or in jet like in hemorrhoids. It's a smear or a stain on the or a streak on the stool. And most of the patients in pregnancy, apart from pain, are bothered about continuous mucoid discharge from the back passes, making perineal hygiene very difficult. Other symptoms can be urinary, dyspareunia, or just irritation and itching, or it may be painless, just causing bleeding. Management principles again: inform the patient, inform the gynecologist, discuss the recurrence rates, but different plans of treatment. Like I said, rubber band ligation, 90% relief, but 40% recurrence. Sclerotherapy, good relief, 25% recurrence. Similarly, in fissure, medical treatment recurrence, topical application recurrence, botulinum injection recurrence. I don't use botulinum in females at all, not to talk about pregnancy, and surgical complications. So discuss that in informed consent. If the patient has gives consent for more than 50% of recurrence of symptoms within 3 to 6 weeks, say surgery will be better option after delivery. So what is the current guidelines? Most of the acute fissures, I'm not talking chronic, acute, which are red, which are fiery looking, which cause anal spasm, they resolve without surgery with topical application, lifestyle and diet modification, and hot saline fermentations. What literature says now, because sitz bath is a very fancy thing, patients put betadine, patients put potassium permanganate, variety of salts. So classically, as well as current evidence says, sitz bath is hot saline bath. So ask the patient to put some common salt in water and sit in that, because a hypertonic solution with betadine or with potassium permanganate will do more harm to the perianal skin than this thing. So normal saline salt, common salt to be put in water and hot warm water, and along with the dietary advice of increasing fiber and water intake. You can add topical anesthetics like xylocaine cream or steroid-based creams, but there is no evidence to support that local in randomized controlled trials, application of topical anesthetics and steroids versus no application in patients given hot saline baths, dietary treatments, stool softeners, and plenty of water. There was no difference whether the topical application was given or not. It is more of a psychological relief that patient feels doctor has prescribed something. Now, only thing topical which helps is a calcium channel blocker or a nitric oxide donor, because they cause smooth muscle relaxant. So first one to be used were nitroglycerins. They heal more than 50% of chronic fissures. Recurrence might be there, but relief is too much, too good to believe. The only thing is increasing the dose or increasing the frequency has no relation to the recovery or healing rates. The ideal way of applying it is to tell the patient to apply it outside back passes 10 minutes before defecation. They should not apply inside. The drug companies supply an applicator which causes more trauma. The fissure is touched by the applicator. There is bleeding. Patients become miserable. So it is it's an outside application on the back passes. It is absorbed through the skin and it acts beautifully. The side effects are there like headache because it's a smooth muscle relaxant, and recurrence rates 50%. But I think in pregnancy, 50% relapse after delivery is acceptable. Another thing, better than this triglycerin nitrite, now we have calcium channel blockers like diltiazem or nifedipine. They are better in terms of healing rates. They are better in terms of lesser incidence of headaches. They are better that increasing the dose and increasing the frequency also increases the better outcomes. So triglycerin nitrites, we apply only before defecation, 10 minutes before outside. While these diltiazem or nifedipine based creams, they can be applied 2 to 3 times in a day. Usually what we tell our patients is first time is 15 minutes before defecation, again only outside, not inside. Patient is always confused because drug companies always supply an applicator. So that causes more trauma, more misery to the patient. They can be absorbed from the skin, so apply them outside 10 to 15 minutes before defecation. And in case of diltiazem and nifedipine, ask the patient to apply it once again at bedtime. So side effects are less. Frequency application helps in alleviating symptoms. So very strong recommendation based on a very good evidence. So highest level of evidence and recommendation 1A. So my choice remains diltiazem based local application, no anesthesia, because agilocan I've seen causes some rashes in many patients. Skin sensitivity, steroids cause a lot of skin sensitivity. They cause lots of skin hypopigmentation and skin thinning. Ultimately, these patients develop cellulitis, and some of them come with abscesses also, and finally fistulas. So I avoid totally. I go by diltiazem, and it has highest evidence and highest level of relief amongst medical things. What is best for stool softening in pregnancy apart from dietary management with papaya and green leafy vegetables to increase fiber? And with fiber, we should remember we should give a lot of water, because it is not the fiber which provides bulk to the stool. It is the water that fiber absorbs and makes it a glue, slimy glue, which provides bulk as well as a slime lubrication. It slides on its own. So along with fiber, tell patients to drink a lot of water. The only stool softener found to be safe in pregnancy is lactulose based. Abbott makes a beautiful, I prefer Abbott's Dufalac sincerely. Even if Abbott is not sponsoring, I always talk about Dufalac because patients find it least syrupy and least sweet as compared to other preparations of lactulose. So lactulose has an additional advantage that it has been shown to decrease pain and decrease mucus leakage irrespective of relief in the symptoms of hemorrhoids or fissure. How it happens, mechanism is not described, not known. So it has been shown to reduce the requirement of analgesics. Botulinum, I said theoretically we should know, but no recommendation at all in pregnancy. If everything fails, which in case of pregnancy will not happen, then we go back to surgeon. Lateral internal sphincterotomy is a gold standard. It is a daycare ambulatory procedure. There are no complications if done properly. It's a gold standard treatment, provides 100% relief if it is done well. On a wider scale, 88 to 100% reported in literature. Literature is skeptical about it because they say it causes fecal incontinence in up to 1/3 of the patients. But Indian population definition of incontinence is, like we know, 4 grades. So there is grade 1 is incontinence to flatus in squatting position. So in Indian population, I think we do not come across patients who think of incontinence to flatus. I'm not supporting that you should do it, but in Indian population, it works well. And these studies are based upon follow-up more than 5 years. And most of it, the best part of it is the only procedure which improves the quality of life in the patient. Because all other medical management and all that, they provide relief from pain, irritation, and local discomfort. Other symptoms of fissure like perineal hygiene, mucus discharge, they persist or they recur. After this surgery, they also get settled. Again, strongest possible recommendation with strongest possible evidence, 1A. Surgical management when LIS has been done by a colleague or it does not help the patient, we have mucosal advancement flaps from upside down, from head side to downside, or we can advance skin from below up, VY advancement. They are better because there is no raw wound. I don't practice them except in failed surgery cases. I talked about spices. I tell all my patients, you might laugh, but I'm being an old Delhiite, I tell all my patients pre-operatively to eat golgappas and drink a lot of golgappa water, because I want them to realize that spices are not the cause of hemorrhoidal or benign anorectal problems. It's a misnomer. So we did a randomized controlled trial and we published in the highest impact factor journal of laparoscopic surgery, to which I contributed. I think I was the first Indian and remain the only Indian to be invited to write an editorial in that. That was in December 2008. So dietary spices have no relation to symptoms of hemorrhoidal disease. It's a fear factor. If you treat a patient well, patient should enjoy a normal spicy diet. Spicy means tasty to the patient, not otherwise these patients are scared for months and months. They come, doctor sahab, maine to ubla hua khata hu, dalia khata hu. That makes quality of life miserable. So that's an important aspect of quality of life. Again, we presented in American College of Surgeons of Meat, which was covered by Medscape and made a CME for American surgeons, that these Kegel exercises is a misnomer. Mulbanda and Vazroli predate Kegel exercises. It is plagiarism. They have stolen our wisdom. So I said yoga is very helpful in hemorrhoid patients. Fisher patients. Apart from Western gynecologists are now publishing yoga helps in breech delivery also. So you can find. So we did biomolecular inflammatory marker study to support our diagnosis, observation as is required by modern scientists. Again, we believe that music is very good. If you ask these patients to listen to their favorite music, it reduces the inflammatory markers. This was also presented in American College of Surgeons and has been published in Journal of American College of Surgeons. So music of patient's choice during pregnancy will help in minimizing what we call a sterile inflammation. We know inflammation can be because of a pathogen, infective. It can be because of the non-pathogenic microbial. It can be because of thermal injury or any other insult. We call them microbial associated MAMS, PAMS or DAMPs. So DAMPs is danger associated molecular pattern. So we study DAMPs. DAMPs are also known as alarmins. हमें डर लगता है, fear होता है, so we are more producing more inflammatory cytokines. Our tolerance to disease goes down. So mental peace gives less inflammation. So our body undergoes sterile inflammation all the time, and all our surgical patients in post-operative period have disturbed sleep, tiredness, fatigue, not because of infection, but because of what is now known as sterile inflammation, which is based upon cytokine storms, which we come to know now in COVID era. So by music and by yoga, we have shown that we can reduce the post-operative and even pre-operative cytokine. So most of all my PGs in last 5 years have done thesis on these topics about reducing sterile inflammation. So we did all these studies with CD markers also, and we found, and this is in non-pregnant patients, but I'm sure if something happens in non-pregnant population, pregnancy is a healthy physiological state with a lot of tremendous stamina and spirit to fight illness. So it is gonna be helpful in those populations also. So music study showed that even recovery from anesthesia was faster. So coming back to take home message I started from this, initial evaluation should include a good history about diet, defecatory habits, toilet habits, lifestyle, and then you should do endoscopic evaluation, that is proctoscopy or sigmoidoscopy, and if needed you should tell the patient to increase fiber in the diet, increase water intake in the diet, not any drink, tell them water, because it's the water which gets absorbed by the fiber. If it is sugary water or a saline water or a juice, it is isotonic or hypertonic. Fiber will not extract water from it. The water will extract whatever water is remaining from surrounding mucosa. And teach the patient the proper toilet, something which should have been done by the parents when the child was growing up. That is to go to motion, washroom, only when there is adequate urgency to pass stools. Not to pass tools because it is convenient, we have to go to office and things like that. If these things fail, we offer office-based treatment which are very safe in pregnancy. If there is an inflamed thrombosed hemorrhoid, it should always be excised, lest it becomes infected and suppurative and causes abscess or fistula. And very minor percentage of patients might need a surgical scalp. And even then, we have procedures. I have not done any excisional benign anorectal surgery, including prolapse, for last 15 or so, since 2008 to be exact, and they can all be managed on a daycare basis painlessly by endoscopic procedures. So thank you very much. At the end, I talked about staplers and endoscopies, but I feel that a fool with a tool is still a fool. So I say technology is just an enabler. Think about the patient as your own body part and take a decision in consultation with gynecologist colleague. And I wrote in my editorial in surgical endoscopy, be an Imagineer. Imagineer is an acronym for I for innovations. You innovate according to patient. M for molecular understanding of inflammation or disease or whatever. A for ancient wisdom, and G for genetics or cultural pool, and then engineer your approach. Thank you very much. Thank you for giving me this opportunity, and I beg for your pardon if I have exceeded the time. Thank you very much.
Thank you, Dr. Agarwal.
I have not exceeded time.
No, you haven't at all. It was extremely, completely spellbinding listening to you actually. And I think
he has been our teacher of our generation, and Yogesh, her brother, is a very, very close dear friend.
So a couple of things before I pass on the baton to Dr. Yogesh. I think, you rightly pointed out that holistic health is extremely important, and we need to move beyond just writing medication for any disease. And that's where mental health, music, and yoga comes in. I must mention, which I didn't mention earlier, that Dr. Agarwal is a very accomplished yoga personality, and he has trained in yoga also. And I think adding it to our medical armamentarium is extremely important. And the second point was that when you mentioned curcumin, I absolutely agree with, all my patients, whether I'm doing a DNC or a hysteroscopy or a hysterectomy, I'm very particular that 1 month prior and probably for the next 3-4 months, I explain to them, of course, curcumin is available as kachi haldi with our patients, and now capsules and tablets are available, but it helps in very good healing and increased immunity. So I also have added it to my practice as a routine. The third point I wanted to know was that if we can avoid, have you felt that, because we know that progesterone changes occur during pregnancy, that to do a staple procedure, if possible, that probably we would get better results if we do it 6 months, 6 weeks postpartum, like we think for other procedures. Do you think that the tissues would, be extremely congested if we had a choice? Would you defer it for about 6 weeks after delivery?
That's a very good point. I don't remember me doing a stippled or any other hemorrhoid procedure, benign surgery in pregnant patient. I don't remember in my career, but I have witnessed it. So as I said, very unfortunate and very rare population will go through the knife of a surgeon, the proverbial knife, the procedure.
And I think
pregnancy-related things will settle on proper counseling, diet, exercise, physiotherapy, and topical application of calcium channel. They are wonderful.
Yeah, that was the next point I was coming to, that you were mentioning diltiazem and topical applications. I know we are on a forum which is a company forum, but we use generic terms. But is there a name or a brand that all of us can try in our practice?
Abbott has a very, very good brand, Fidonal, which is my choice. Before that, my choice was Diltiazem. It became unavailable somehow for a year. So I started asking. Then I came across this, and now I am used to Fidonal.
Thank you so much. Moving over, I think we are extremely fortunate enough to have today Dr. Yogesh Agarwal also with us. Can I have his CV, please? Dr. Yogesh Agarwal is an extremely accomplished, I still can't, Dr. Agarwal, I think you'll have to stop sharing your screen so that they can, thank you. So Dr. Yogesh is an extremely accomplished general surgeon, endoscopic surgeon, and a bariatric surgeon. He is director of Life Care Center. He was formerly chairman surgical specialties at Niyati Healthcare. He is director and head GI and minimal access surgery and bariatric surgery, Max Hospital, Saket, and vice chairman Institute of Minimal Surgery at Southern Gangaram Hospital. We would love to hear what you have to say on this topic, Dr. Yogesh, because I think all of us are extremely fortunate to have two surgeons in our midst today to speak on this topic.
Thank you very much, Dr. Meenakshi. I am really obliged by what you have said. And hearing Bridge, I think he has covered everything. And Bridge, I go back to almost 30 years knowing him and being very close friends. He is a surgeon par excellence, no doubt about that. But he is also a lateral thinker. For me, I would say I just focus on my surgery and on my patients, and so my vision was a very, you can say, tunnel vision, surgery. His is excellent surgery, then the lateral thinking in terms of how best results can be offered, what are additions and benefits which my patients can be given. So Bridge and me have interacted quite a few, especially in our travel overseas and meetings, and we having spare time and discuss apart from surgery, he has huge interest in Indian mythology, I would say, in religion. I think talking to him, I learned more about my religion, Hinduism, than I ever have read in my last 60 years of my life. So he is a 360-degree personality, and it's always a pleasure to interact with him. Now, coming to the topic specific, he has explained everything. Well, the dictum, or as far as today's topic is concerned, in a pregnant lady, we should be as conservative as possible. And knife has to be wielded as the ultimate last resort, not as a earlier option. That is the dictum which should be followed without any question mark on it. And the methods are extremely simple. So conservative lifestyle management in terms of your diet, your exercise, or activity. Basically, apart from all this, the cessation of activity by a pregnant lady is one of the most important contributors to getting constipation. So an active lifestyle added on with adequate hydration, and the reason for hydration, Dr. Bridges clearly told, and hydration with water, not with any hypertonic solutions as juices, etc. As Dr. Bridges told you the reason why it has not to be done. Patients को बोलो liquid लो, वो जाके juice पीना शुरू कर. Nimbu pani and juice, these are all hypertonic solutions. Water, plain water, is the best hydrator of the body. Apart from that, the minimal medication in terms of, yes, lactulose, one is a wonderful drug. Dufalac is, I think, the most easily tolerated by a patient compared to the other brands like Luz, etc., which patients complain they are extremely sweet, and prescribing them to diabetics is a nightmare. They really come back with they are not compliant patients. So, very simple and basic step. Surgery, of course, is the last step. And I really appreciate his lateral thinking in terms of music. And the reason he says, very clearly pointed out in his work of his undergraduate, of his postgraduate, in their thesis, how the inflammatory markers are understood and how they reduce if you follow active yoga lifestyle, yogas in your daily routine, music, listening to music, calming yourself, and how they help in reducing the cytokine storm. My introduction to cytokine storm has been in this COVID era. I really have understood it much better. And I would say, yes, inflammatory markers, if they rise, they cause a havoc in the body. They have to be controlled. And I think his mechanism of controlling the inflammatory markers is really praiseworthy, and it should really work. I am going to try it in my patients, but as far as his message, it is very simple and clear. Surgery, the last resort. And these are hemorrhoids and fissures are one of the commonest problems we face in pregnant ladies. Dr. Jain refers to me a lot of these patients, but I just keep my itching fingers away from these patients to be used on some other patients. Thank you so much.
Thank you for your indulgence like a friend. I think much of it was exaggeratory praise.
No, never, Dr. Brett. Such a pleasure to be knowing you.
Thank you. God bless you.
Thank you so much, Dr. Yogesh. Dr. Sharda Jain, ma'am, if you would like to add some tips and points of experience from your practice.
As far as these two problems are concerned, in fact, if a gynecologist is very careful to tell these patients that you have to avoid constipation at all costs. If this particular part is taken care of, I feel a very common problem of piles do not occur. I find, as the grading has been very beautifully said, and I repeat it again, I find,
Ma'am, we can't hear you, ma'am.
She is muted herself.
I will say this particular problem, I repeat again. If the gynecologists are careful not to avoid constipation in their patient, the problem does not occur. In the last 10 years, I will definitely say that, bleeding piles will occur in 1% of patients. But when a gynecologist examines, they do not find any piles. And the grade 4 piles, which remain protruded all the time, is very, very rare. I think, 2 cases. And that also, those are the people who have taken their consultation very late. They have referred from other places, and then, people like us cannot treat, so we send them to the surgeons. So I find, very rightly he said that I have not seen in my gynae practice any patient has been operated for piles during pregnancy. In a postpartum patient, definitely pose problems. Postpartum patient of our patients are definitely pose problems, especially if there's an episiotomy has been there, and if it slightly gets infected, the piles get aggravated at that particular time. And I will tend to agree with him that the local treatment which is available, we should try to use it, and never, I find, if one has to use themselves, those applicator which is provided by the drug house, it is going to be difficult. It is the surface, and mainly it's a hot fermentation which really helps them. So I think, very rightly, this particular problem does not occur. But I find, during pregnancy, the fissure definitely give problems. When there is a constipation, the fissures problem occur. And I think the good surgeons definitely see to it that, they do a manual dilatation, and then later on, once the pregnancy is over, they go for the surgery at that particular time. So I have only these words to say.
So 2 important points which come out of this is, which I think Dr. Agarwal also said very clearly, that probably 90% of the problems which occur in pregnancy can be avoided by not following a sedentary lifestyle. So healthy eating and regular exercise probably takes care of 90% of the common problems which occur in pregnancy. And we all know that constipation can be simply managed by these things. I think another pointer which is here, which is very important, is that when we have a patient, and this is especially for all our gynecologists, that who comes with, say, bleeding during pregnancy, they'll call you up in the middle of the night or the early morning that I've had bleeding. You must confirm that it's vaginally and not per rectally. Because many of them, I will always tell them, just put a tissue in your vagina and see is it coming from the vagina, because bleeding from the rectum with their constipation is also quite common. And that is a time where you should start taking care of their bowel habits if they haven't been taken care of already. Dr. Mala, is there anything you would like to add from your practice for our audience today?
Whenever antenatal patient comes to us in the first visit itself, we have to guide them regarding their diet. That is very important. We have to impress upon them the importance of high roughage diet, good diet, and to avoid constipation, as Madam already said. We have to guide our patients to avoid constipation, and if they are having constipation, to treat them with diet and exercise as well as minor things. And as Madam has said, we have never seen our patients having grade 4 piles needing to have surgery during the antenatal period. And definitely,
one thing I have also learned from Dr. Yogesh is that, he says, whenever the piles get prolapsed, you should always reduce it very gently. Very gently they should be reduced. So I think, one should not be hurry up in this. Very gently, applying a lignocaine gel, and very gently they should be reduced, and never strain for micturition, never strain for stool. And that is one thing, both the Agarwals have very rightly stressed on these particular 2 points.
We have time for some questions, because there are some questions.
Yes.
What is the safest antiemetic in pregnancy, and what should be starting and maintenance dose?
The safest antiemetic in pregnancy is that you should use B6.
Yes.
3 finger below the wrist crease, and just below the 3rd finger, you should put your thumb and press it for 3 minutes. This is good. Secondly is ginger should be used. It is not this much of ginger. Very little amount is required, but it can be taken as tea, it can be taken as ginger ale, and salads and all people can use it. Thirdly is, we are all aware about vitamin B6, and this is with the doxylamine. These preparations are available. They are available 10 milligram each and 20 milligram each. As far as this preparation of vitamin B6 with doxylamine is concerned, we can use till 4 tablets, 10 milligram each. 4 tablets in a day can be used. We should not be miser. We should not use a homeopathic dose that 1 tablet will be enough. No, it is not enough. Some people are vomiting, then you have this particular thing. Both these things are safe. Then sustained preparations are available with 20 milligram and 20 milligram. Very frank with you. Too much, tell them you have to get admitted. They do not prescribe single antiemetic. So if 1 day admission is there, cost them about $2,000 to $3,000. Disappear. The medical and the surgical cost, and should not use left and right all these drugs. Dr. Ahuja, what do you have to say? You have to unmute yourself.
Yes, ma'am. Absolutely correctly said. I think, we should be relying less on drugs. I've been actually trying that P6 point ever since you said it. And frankly speaking, I remember in the last meeting that we'd had like this, you had talked about not using ondansetron. And I think it's made a big difference in one's practice, because I think from every CME, if we can take even 1 or 2 points back home to inculcate in our practice, I think that's good enough. And today we've had a lot of points from both the Dr. Agarwals, from you, madam, and I think it's really been enlightening for all of us here today.
No, I definitely feel that we should adopt the practice. Gynecologists are soft corner. If they are pressurized by the family members of the patient, she's vomiting, they prescribe any drug. उनको ये मालूम नहीं है pregnancy में नहीं use करना, फट से injection लिख गया, ठीक हो गया. And the effect will be seen 1.5 year later. And litigations are definitely rising. And once you know it is there in a black and white, in this particular thing is not to be used, they are going to blame it to you.
Absolutely.
Dr. Mala, what do you have to say?
Yes, definitely. We have to be very careful in prescribing drugs.
It would be common knowledge, say like there's a cleft lip or palate, and any patient
very
if you see that, we are going to blame it to this, whether it could be anything else also. So it's very, very important to keep ourselves safe.
Doctor, any other question?
The other question is, how long can doxylamine and pyridoxine be given in nausea and vomiting of pregnancy?
I have seen, I've told you, less than 10% of patients will continue throughout pregnancy vomiting. And there is no point, in between you stop it again, she says, I'm trouble, she can take this particular drug.
Absolutely.
It depends on the patient profile. And it varies from patient to patient.
Yes,
Absolutely.
It all depends upon patient and patient. And I'm sure there is always a triggering factor. Once you talk about hospitalization, 3/4 the vomiting disappears.
Another question is, in your clinical practice, what has been the prevalence of hemorrhoids or anal fissure in pregnancy?
I did tell you that. I find 1% of patient of mine definitely bleed during pregnancy. And when they bleed during pregnancy, then one has to take a decision what has to be done. But I find, grade 3 and grade 4 piles especially bother us in postpartum period. In pregnancy, they do not bother so much. In postpartum period, they bother. Because at that particular time, हमारी जो elder ladies हैं, rest karo के चक्कर में, you find all the problems they start.
So you have also answered this question. In which trimester are anorectal complications associated to be most commonly observed during pregnancy? So it's mostly during the postpartum period.
Postpartum.
Yeah. What is your experience on the use of flavonoids in pregnancy? Can we use it in pregnant women? Are there any guidelines recommendation for use in hemorrhoids? Dr. Agarwal.
No, ma'am. As I said in my talk, the mechanism of action is very good. They are venotonics, phlebotonics. They increase lymphatic circulation as well as venous circulation. They minimize symptoms of congestion like pruritus, mucus discharge, edema, and discomfort in sitting or pain or maintaining perineal hygiene. But there is no study, randomized control trial, whether they are safe. That was my first slide. But still they are being used commonsensically, assuming that they are topical. But I'm sure now more and more data is coming about how drugs can be absorbed from skin and can be having an undesirable effect. So I will prefer not to use them, and they are not required because majority of these ladies have a tremendous fighting spirit, and with little bit of counseling from our side about diet, appetite, and perineal management, and they get well soon. As Sharda ma'am said, only 1% will need a surgical consultation, and that can be postponed to postpartum period.
But sir, let me be very frank with you. Gynecologists are in habit of using phlebotonics left and right when patient complains of a bleeding per rectum. Dr. Ahuja will speak and Dr. Mala will speak because they see a lot of obstetric patients. Our people are in habit of using that particular drug similar to MSET, which I was talking about. So let them comment.
Yes, ma'am is right. It's
Left
very
and right
valid.
they use.
Yes, definitely.
Commonsensical,
So enough.
but there is no evidence against also. But they say absence of evidence is not evidence of absence. So
Correct.
there is,
Yeah.
if there is no evidence of negative effect, doesn't mean negative effects are not there. So we should be careful.
I think here again the role of holistic health comes in, and counseling, effective counseling. Sometimes I think many gynecologists have a busy OPD and they don't want to spend time, and that quality treatment you're not giving, not realizing that it is going to get you into trouble. Like you feel it's easier to write just a couple of medicines rather than counsel on the diet, exercise, activity. That's where I think we are doing wrong, and it's a learning process for all of us. That amount of work you do, the more important than the quantity. And it's a habit.
And I find, now with the ART use, a lot of progestogens are being used in our first trimester. We find many patients complaining of constipation during that particular time. And each gynecologist has to see to it that we tailor the dose of progestogens accordingly, because it just definitely promotes the constipation part of it.
It's a smooth muscle relaxant, it decreases bowel motility. So if you're using progesterone, it is a good idea to simultaneously ask the lady to increase his salads and papaya and avoid fruits which are sugar syrup. Like patients are very happy with fashionable imported fruits like kiwis, orange juice, mosombi juice and things. So I tell my patients,
papaya तो हिंदुस्तानी लोग लेंगे नहीं, क्योंकि उनकी माता जी ने और उनकी ग्रैंडमदर ने इतना बता दिया कि papaya तो यूज करना नहीं है. So I find in any of our Western books it is not mentioned at all that the papaya should not be used. But I want very categorically, when the patient is bleeding per rectum, what should be used by you?
We encourage salads and fruits.
one fancy salad, broccoli. For a fanciful lady, you can talk about broccoli if kheera doesn't do the trick.
We tell them
I think postpartum period also that myth that they have to have less water, otherwise bloating will occur. That is a problem. They're losing so much water because they have the ACs and fans are switched off, and they're losing water in the breast milk. And the relatives will say pani ni pina, which increases the constipation and the pile.
Dr. Mala, any more questions?
no more questions.
Before we part,
Any last minute, Dr. Yogesh wants to say something, last minute, Dr. Yogesh?
before we part, I would like to share a secret about Dr. DG Agarwal. Very, very few people know about it. Dr. DG, if I have the permission to say, Dr. DG has tried to do Hajj twice, and he has been stopped at the last entry point to Mecca, Medina, wherever he is gone. So, as a Hindu, he has been to Hajj twice. Am I correct, Dr. DG?
No, I don't know. Last year I went to with Sneh. We went to Al-Aqsa Mosque. We were inside Al-Aqsa Mosque. So just before COVID struck in Feb.
This is all I can say because that is in public domain now. with pictures.
Now we have two great gynecologists with us. Dr. Ahuja, you want to give any last minute message? And Dr. Mala, you want to give any last minute message? Because we gynecologists are soft, we get pressurized by our patients and their relatives about the drugs in pregnancy.
I agree with you, ma'am. Absolutely. We all need to learn that we need to spend more time on lifestyle changes, on the diet, and not get pressurized to just write medication. It does take more time, like I said. I think it's a habit that we all need to learn, that whether it is pregnancy, whether it is PCOS, whether the problems, we are not dealing with tuberculosis now, that 4 drugs have to be written and that's the end of the story. A lot of emphasis needs to be given to holistic health. And today we've had eminent speakers talk about holistic health, which has really been, I mean, I hope it's an eye-opener to everyone that they should be very careful in their practice. Otherwise, and you are a medical legal expert, so that way also it becomes important. So, you know, you need to incorporate these things in your practice, the confidence that it is going to change the management if you are using holistic health parameters. And that's why I personally feel going towards it positively, not getting pressurized by the patient and their relatives, explaining, because I think half the time, you know, wo patient phone karta hai, dimag khara, acha dawaiyan likh do. You know, let's just get out of it. That is not the policy that you should follow because it's not correct medicine practice. And secondly, like you said, it can land you up in medical legal trouble.
Dr. Mala, when Dr. B.B. Agarwal has said that no phlebotomic agents, what is your preference for using a bleeding per rectum?
I didn't say that, ma'am. I say there is no evidence to support their use, but absence of evidence does not mean absence of side effects. Evidence. We are using it based on common sense. Say that, ma'am. I say there is
counseling, as Dr. Ahuja said, is very important. And as Madam said, that when the patients have unwanted pregnancy or unplanned pregnancy, then they have more incidence of nausea and vomiting of pregnancy. So nowadays, the women are coming for pre-pregnancy counseling. They are planning the pregnancy. Once they're mentally prepared to have a pregnancy, they are ready to take the package of pregnancy. So again, we are counseling is so important. And of course, we have to guide our patients regarding their diet, their exercise, and their lifestyle management. And that goes a long way in preventing nausea and vomiting of pregnancy, and also their constipation habits.
And ma'am, I want to add one thing, remembering from phlebotomics thing, versus calcium dopecelloid, because I have seen patients bleeding रोकने के लिए वो blood रोकने की दवाई लेते हैं, so blood becomes thicker, clot can form anywhere. I have seen patients going blind by simple 2 doses of calcium dopecelloid, taking calcium dopecelloid for bleeding hemorrhoids and retinal artery thrombosis, cerebral vein thrombosis. So I have not seen literature, but I am sure it has a potential to compromise the placental circulation and uterine circulation also. So it is better to give blood thinners rather than blood stopping.
Yeah, and coagulation factors are all change in pregnancy. Now all of us know, we've all done D-dimers and all in pregnancy and realized because of the COVID era, we've all realized that they change in the 2nd and 3rd trimester drastically. So we know that these can create an impact. I think also sharing the side effects of the medications should, you know, put the fear of not using medications in patients' minds. So it's not a bad idea to share that, you know, yes, there are medications which people are using left, right, and center, but they may have side effects. And that's why probably using home remedies like ginger and using the P6 method might actually be more helpful in these cases. I think that's the way to go also. You have to put the fear of God in yourself and the fear of complication of medications in the patients and not, over-prescribe medication.
When the patient comes to me for the first time in pregnancy, I definitely take their focus to Garbh Sanskar. I tell them this is the time that you have to construct the whole your whole personality of your child. And I tell them backache, constipation, and nausea is 100% you will see. And you have to see right in the beginning that you take care of your diet, Constipation is the bad part. The backache part, I will take care of it by telling you the right exercise. But nausea is, accept the pregnancy very gracefully, your nausea will disappear. These are the signs that you are not liking this particular pregnancy. So go back, chintan karo, pata chal jayega ki why are you vomiting? This is sign that you want to throw away this particular pregnancy. I always tell them that this is the sign that you want to throw away this particular pregnancy or you're not liking it. You may be newly married and yet there's a pressure from your family. And then I find that there is an acceptance in 2 weeks' time. I tell them about the Garv Sanskar, so her whole focus changes completely. She will take care of her diet. She will see to it that all the good values can be is given to the child. And not only Abhimanyu wali baat to bahut choti hai. You can teach everything to the child if you want, if you and your husband wants to deliver the same. So I think that that's a topic by itself. But I feel again, medication during pregnancy should not be taken lightly. You should only prescribe. This jamana aajkal litigation ka ho gaya, everything is in a public domain. Aap khologe history mil jayegi wahan par. Ondansetron came as an antiemetic for chemotherapy, for radiotherapy and advanced cancer surgery. When gynecologists started using, in spite of the clear indication it is not to be used in pregnancy, it is used. So all gynecologists who are listening me in India, please do not use this particular preparation, tablet or oral, however your patient is vomiting. You get them admitted, take care of the fluid and electrolyte imbalance, it will settle down. Mala, closing remarks.
Yes, we had a very nice lectures from Dr. Sharda Jain and Dr. B.B. Agarwal. It was very enlightening and good, crisp messages have gone to our young budding gynecologists who have been, all the delegates who have been listening to today's evening. Note to Ondenstrom and lifestyle management, good diet, yoga, exercise. This will go a long way in preventing nausea and vomiting of pregnancy as well as constipation during pregnancy. I think this ends this evening talks. Over to you, everybody, and namaskar to all.
Thank you, everybody. Thank you very much.
Thank you, sir.
Thank you so much.
It was a pleasure listening to all the stalwarts. Over to you, everybody.
Thank you all. Webstream, you can close the meeting. Thank you.
So much. It was a pleasure.